Okay, good morning. I think we're going to get started. Welcome everyone to Grand Rounds. Happy New Year. I'll start just with one announcement, which is that we have an exciting Grand Rounds next week as well. Next Wednesday, January 12th, Dr. Suzette Evans from the department will be speaking. And the title of her talk is Sex Differences in the Behavioral Responses to Drugs of Abuse. Translational evidence from human and non-human primate laboratory studies. So I'm really thrilled about today's Grand Rounds. It is part of a series of clinical updates. And this series stems from an initiative in the department that was spearheaded by Melissa Arbuckle and Lou Baptista to do pre-COVID clinical updates CME series for our department to make use of the extensive and broad clinical expertise in our department to keep us educated about the state of the art in clinical care across a wide area of clinical disciplines within psychiatry. And during COVID, they had the excellent idea to transition that clinical updates, which was like a weekend long extended CME program, to into Grand Rounds and to do topical Grand Rounds clinical updates to learn from our peers and colleagues who are at the cutting edge in different clinical areas in the department about standard of care, current standard of care, and new developments in clinical treatment. And so today's session will be on in the area of addiction and substance use. We have another session scheduled this spring that is devoted to the use of psychedelics and dissociative medications clinically within psychiatry for treatment. We're hoping to do one on brain stimulation after that. And we would welcome ideas from the department about other areas that you'd like to hear about as part of this clinical update series. So before I announce our speakers, I wanted to remind people that we would welcome questions that you could pose at any time throughout any of the talks that you'll hear. You don't need to wait till the end. If you have a question that pops into your mind, throw it in the Q&A button in the bottom of the screen if you hover to the button, not in the chat, but there's separate Q&A section. And we will try to prioritize trainee questions. And so if you're a trainee, please put the word trainee at the beginning of your question, and we will make an effort to prioritize those questions. We're really lucky to have 3 speakers today. They're each going to give brief talks, and we will save questions till the end. And so we'll try to keep, hopefully, I think we'll probably have 20 to 30 minutes for an interactive discussion and questions for all of the speakers at the end of the session. So throw the questions in at any time, and then we'll have a lively discussion at the end. Okay, so with that, we're going to get started. Our first speaker today is Dr. Robin Williams. Dr. Williams is an assistant professor of psychiatry. He's funded by a NIDA K23 award, looking at the addiction treatment gap and systems-based practice to improve quality of care for the treatment of opioid use disorders through the development of an opioid use disorders cascade of care. This work has been invited as expert testimony at NIH, multiple NIH locations, NIDA, APA, and SAMHSA. And he's been awarded the American Psychiatry Association Health Services Researcher of the Year Early Career Scholar Award in 2019. He also serves as the medical director for a large telehealth buprenorphine treatment provider and the New York region of the American Academy of Addiction Psychiatry. And he's the PI of a NIDA CTN study on methadone maintenance treatment outcomes following COVID-19 reforms. We're really thrilled to have Dr. Williams speaking with us today. The title of his talk is A Novel Telehealth Model for Improved Retention in Opioid Use Disorder Treatment. Very timely for the times that we're finding ourselves in today. Dr. Williams, welcome.
Thanks so much for having me. As Dr. Miller mentioned, a lot of my research is related to looking at patient trajectories with medication-based treatment for opioid use disorder. And today I'll be talking specifically about a novel program that I've become involved with. As you mentioned, I'm a medical director for Ophelia Health, as an example of telehealth platforms that have emerged in recent years for treating these patient populations. My research is funded by NIDA and SAMHSA. I also received some consulting fees from NQF and CMS for quality measure development for opioid use disorder, and receive consulting fees and equity from Ophelia Health, which I will be talking about as a case study today. I won't belabor this. I think we've all heard by now that as of April last year, over 100,000 overdose deaths just in a 12-month period, the great majority being from opioids. All those stimulants or the co-use of stimulants are increasingly contributing to this as well. So this is a huge problem. What can we do about it? We know for a long time now, for decades, that really the gold standard of treatment has been the use of medications, the long-term, if not indefinite use of medications. Mostly in the US, that's buprenorphine, although there's a sizable number of people on methadone or receiving, to a lesser extent these days, extended release naltrexone, but 3 different MOUD modalities. And buprenorphine is the one that can be prescribed as an opioid agonist treatment out of a primary care office, whereas methadone, of course, has to be in licensed methadone programs. So we think now that there may be as many as 2.5 million people, as of, this was SAMHSA data from 2020, over 2 million people receiving buprenorphine in a given year, which speaks to the scale of the crisis, and that these formal estimates we often hear of maybe 2 million people with opioid use disorder are dramatically lower than the truly affected population, which is probably closer to 5 or 6 million people. So we have this treatment. It works really well. You can see on the right that there are immediate and dramatic reductions in adverse events, such as overdose and ER visits and total billed costs to insurance plans. And yet our overdose rates have continued to increase to sky-high numbers. So why is that? Even though millions of people may access at some point in a given year one of these medications, the great majority of the affected population do not. So what we're looking at here with the gray circles is about 80%, an estimated 80% of individuals with opioid use disorder in the US do not receive treatment in a given year. And if you look at the light blue dots, among those who do receive some treatment, it's not evidence-based treatment. The evidence base, which has been replicated across settings and populations, as I said, for several decades, really is the use of medication-based treatment, typically with methadone or buprenorphine. And yet 2 out of 3 treatment programs that are treating care episodes for the diagnosis of OUD do not use medication. And part of what I'm referring to for the third who are accessing MOUD is that a lot of them are actually getting it from the street before they even enter professional care, because it's just so difficult to access providers. And there are many barriers that I'll speak to. In terms of barriers, funding alone is not enough. So 5 years ago, Dr. Adam Basaga, a professor in our division, and I wrote a commentary in the New England Journal about the need for regulatory reform, learning from the AIDS epidemic from the 80s and 90s. It's not just about funding. If we keep paying for the same thing, we're going to get similar results. We really need to do different things. Just last month in Health Affairs, I had a similarly themed article about the need for regulatory reform. Well, COVID, of course, gave us a ton of regulatory reform literally overnight. And I peg a lot of this to March 15, 2020, in part because that's when SAMHSA revolutionized, so to speak, the regulations on methadone programs. And this had ripple effects. Medicare allowed for payment for telehealth services, even audio-only telehealth services, rather than requiring video capabilities. That's what AV is referring to. There were really a whole smattering of regulations that changed dramatically. And I think especially right now, there's a lot of conversation about the Ryan Haight Act of 2008. And if you're unfamiliar, this was a law that was passed by Congress to limit the sales of controlled substances over the internet. The concern was that people were going online with minimal oversight from prescribers and getting controlled substances. Of course, this had the unintended consequence. In retrospect, it's clear that especially savvy teenagers, younger adults, went online and bought drugs from drug dealers and internationally and from the dark web, which were much more dangerous. And so, if anything, there's been a push for repeal of Ryan Haight for years to allow for high quality telehealth with licensed clinicians who could really treat patients. And we kept thinking this would be repealed, and it kept being pushed off year to year. And then all of a sudden COVID happened, and it's been suspended under the public health emergency since. there are tons of regulations that impact telehealth. And so we're really in a new era at this point. And one of the themes I want to emphasize today is that there's a whole range of quality. Telehealth is not telehealth. There are tons of different kinds of programs with a whole range of quality. In some programs, patients come in and they see the same prescriber, the same clinical care team over and over for their care episode, whether it's months or years. Others, they have one-off interactions with different people who sign off, or bots even, who may sign off on the information that they send in asking for different kinds of prescriptions or treatment options. They can be for a range of conditions, singular conditions, a mix of conditions. One thing that I think is really important to think about, and of course at Columbia, we saw, I believe it was well over 90%, 95% of our FGP visits in the outpatient program go to telehealth very quickly. There are a lot of programs that adapted to needing to be seeing patients in a remote setting, but there are also novel startups that we might say were digital first, that were designed to be remote only care. So lots of different aspects to these. There are a ton of programs. I'm always shocked at how many different startups and programs there are that exist. This is specific to telehealth, but telehealth, if you look at digital health related companies, are only about 1 in 6 of the top 150 digital health related companies. And if we look at what we would think of as telehealth in terms of at the bottom, pure virtual care or a hybrid virtual in-person care models, 3 of these, about 25 programs, are specific to addiction treatment, one of which is Affiliate Health that I'll talk about as a case study. This is a platform that I became involved with to help start up a few years ago, specifically for the treatment of opioid use disorder using buprenorphine. And it's been very effective because it overcomes geographic barriers. I'll show some outcomes from this analysis looking at the geographic distribution of our patients. We've long known that 40–50% of US counties do not even have a single DEA waivered buprenorphine prescriber within the county. So for rural underserved areas, this has been a major impediment to care. Of course, work and family commitments, childcare impedes on patients' abilities to be present between 9 and 5, especially if it needs to be multiple days a week based on program requirements. A lot of stigma is ubiquitous throughout the addiction field for the patients and for the providers, frankly. And so what we thought of is these gray dots in the earlier slide, the 80% of people who don't get treatment in a given year, a lot of them, they're not even diagnosed. It's just a population that's unconnected to care. So telehealth is a great way to reach people who otherwise wouldn't be receiving services at all. So Affiliate Health, in part through my leadership, really the platform is meant to be a high quality, evidence-based care that is modeled after the Massachusetts nurse care management model. So for those of you who aren't familiar, this really grew up in the early aughts as buprenorphine was getting FDA approved to think about how to integrate buprenorphine maintenance treatment into primary care settings. So this model's been around for about 15–20 years. And patients on a virtual care platform will meet with their care team, their nurse, the prescriber is typically a nurse, a care coordinator, come in for weekly visits as they stabilize through drug testing and clinical appointments. They then get stepped down to every other week or monthly appointments, although they can be seen more frequently as needed. Lots of information on this slide, but the idea here, adapting the triple aim from the IHI, but adding in a quadruple aim where we're also really thinking about the clinician experience in the bottom left. We think that telehealth can be a really effective way to do this. So we have an analysis of our retention, and the NQF, the National Quality Forum, which is an agency that either endorses or declines to endorse quality measures for CMS to use in Medicaid and Medicare plans, a couple of years ago endorsed a 180-day continuation of pharmacotherapy for OUD measure. So meaning someone who starts buprenorphine, someone who starts a methadone program, we want to look at a population level under a given system or insurer. Are they getting their populations through at least 180 days of uninterrupted care successfully? Because we know that that's really a minimum duration of treatment before patients start to have long-term benefits. And frankly, it's probably much longer than that. But our standard of care currently is that only about 30% of people make it to 6 months. So if we could nudge that number up, it would start having benefits. And retention has long been, for those of you outside the addiction field, retention has long been the primary outcome in addiction treatment studies, because we know that patients who retain and care longer do better. This has been shown across different substance use disorders and different treatment modalities. So we were looking at a minimum of 180-day retention among this patient population who had new intakes. We had a washout period to make sure it was a new intake between July 1st, 2020 and April 15, 2021, which would allow us to follow all of these individuals, wound up being 475 individuals between New York and Pennsylvania for at least 180 days. They were recruited to the CARE platform by online ads, the way that you might recruit for a clinical trial. But this was Google ads, Facebook ads, and then patients would go to the website and then set up an appointment. And we did, for inclusion criteria, limit the sample to people who were in care at least 7 days. This is consistent with precedent literature of multi-state buprenorphine patients, in part because some patients choose not to initiate therapy or are only given a short 1-week taper or detox prescription, which is not our model, but in keeping with precedent literature, that was the inclusion criteria. And we defined discontinuation as going 60 days without any medication, used a Kaplan-Meier survival analysis. We also had secondary studies where we looked at USDA-based rural urban coding for geographic residents, and then also compared our retention rates to studies that have analyzed multi-state Medicaid and commercial beneficiary retention outcomes on buprenorphine. In terms of the included population, we had, and this is in lockstep, I do a lot of studies with Medicaid claims with large buprenorphine providers, multi-state buprenorphine providers in the country. And often what we see is that the mean age is around 35 to 40 years old. That's exactly what we found here. Typically 60% of the population are men. Here we found 41% were women, most providing childcare. The great majority were Medicaid beneficiaries. Again, this is very similar to what you would see if you were to go to a clinic, a treatment clinic or FQHC or buprenorphine program across the country. And what we found was that 80% of them didn't even have a primary care doctor. 3 out of 4 had never been on prescribed medication before, and at least a quarter, we're guessing this is an underestimate, were transitioning from street bupe or non-prescribed bupe. Literally meaning that they were getting bupe from Suboxone or buprenorphine from their drug dealer, or sort of trading or bartering or buying from friends and family. So I think it speaks to the motivation, the treatment readiness, and the lack of access that patients have traditionally had. These are 2 heat maps looking at the state of Pennsylvania and the state of New York. It's kind of easier to see the state contours on the left, where we're depicting this is based on the SAMHSA treatment locator, where X-waivered providers are located in the 2 states. And then you can see where these 475 patients were distributed based on their residence across the 2 states. And there's way more coverage, especially in Western PA, Central PA, and Western and upstate New York. In terms of retention, what we found was that 69 to 70%, I think it was 69.1%, of our patients were retained in care at 180 days. And that's compared to Medicaid populations in blue and commercial populations in green, commercially insured populations. If you look across studies that have examined patient retention on buprenorphine, our rates were about double. And from what I've heard from other buprenorphine telehealth companies, they also see rates that are much higher than what we've seen in precedent literature for similar kinds of programs. And in this case, I think because of the telehealth model, it makes it so much easier for patients to stay in care, that they're able to attend their appointments and adhere to program guidelines. This is beyond the scope of the study that I presented, but I think it's important to include because these are a couple quotes on the right from patients. And I was not familiar with the Net Promoter Score, but an NPS is used mostly by businesses, companies. So you can see Apple, for instance, as a comparison. But I think it's a useful concept to think about in terms of healthcare. And of course, we have the Press-Ganey scores out of hospitalizations, and there's been growing interest in patient-reported outcomes or PROMs, especially for addiction. And we want our patients to be happy, and patients will stick with their care if they appreciate it and find it easy or even like it. And in this case, the patients are extremely happy with the telehealth platform. And what I'll tell you that one of the questions we received the most when we first started seeing patients, and we really weren't a known entity, was whether we were a scam, because the patients really just couldn't believe, the individuals approaching us really couldn't believe that it was possible to see a nurse or a doctor remotely and be initiated on buprenorphine, because they thought this was something that would have a ton of requirements, daily group for months on end, all of these other things. And I think that this is a whole area of innovation, that this is one example around opioid use disorder, but that we can think about not just adapting our traditional programs to virtual platforms, but also thinking about how to be innovative and what are the key ingredients for really getting high quality care to patients, so that they're not buying from dealers or going online to websites or using asynchronous bots to order medications or drugs through the internet, but to really have access to high quality care the same way that they would in person. And I think COVID has really shifted the way we think about what's possible. Thank you.
Great, Robin, thank you. That was a fantastic talk. So we're going to move on. I just want to reiterate for people who have joined after our initial announcements that we are going to have 3 speakers today. I welcome you to throw questions into the Q&A at the bottom throughout, and we'll get to them during a conversation, a Q&A that we'll have at the end with all 3 of our speakers. Okay, good. So we're going to move on to our second speaker of the day, Dr. Jeremy Kidd, whose pronouns are he, him, his. Dr. Kidd is an assistant professor of clinical psychiatry in the Division on Substance Use Disorders at Columbia and NISP. And for over 10 years, Dr. Kidd's research has focused on the intersections of sexuality, gender identity, and substance use to address substance use disparities among lesbian, gay, bisexual, transgender, and queer populations. He has a K-23 Career Development Award from NIAAA to develop a culturally tailored psychotherapeutic intervention for transgender and gender non-binary individuals seeking help for alcohol use disorder. And he has a number of other research collaborations, including using insurance claims data to investigate opioid use disorder among transgender individuals, and to develop resources and policies to increase the availability of LGBTQ affirming addiction treatment. And then clinically, he also works as an attending psychiatrist at the Washington Heights Community Services through NISP, providing general psychiatric and specialty addiction treatment to patients with severe mental illness. And today, Dr. Kidd will be speaking to us about providing affirming care to LGBTQ+ patients, updates on research and practice. So welcome, Jeremy. Thank you so much. You're muted, Jeremy.
You would think after 2 years I would have this down. Thanks, Jeff, and good morning, everybody. So I'm excited to talk with you all this morning about one of the groups. The theme for today that we put together was reaching some of the margins and the people and the populations that have often been marginalized from traditional treatment. And one of those groups is LGBTQ+ patients. So I'm excited to speak with you this morning about some ways that we can improve affirming care for this population. So here's some information about my research funding, as well as the collaboration with the unpaid collaboration that Jeff mentioned, looking at insurance claims data. So I'm hoping that over the next 15 minutes or so that you'll be able to recognize treatment access barriers for this population with regard to mental illness and substance use disorder treatment, that you'll be able to name some strategies for creating affirming environments and understand the role of cultural adaptation as we discuss one example of a culturally adapted treatment to improve access and outcomes for LGBTQ+ patients. Many of you are probably aware of the substance use and mental health disparities for LGBTQ+ individuals, but I just want to remind you of those here. This is data from the 2013 NESARC that compares the prevalence of mental health conditions between heterosexual, gay, lesbian, bisexual, and questioning individuals. And as you can see, for each of the disorders listed here, the prevalence is higher among the LGB individuals than among the heterosexual or straight group. And I want to draw your attention particularly to the column labeled bisexual, because studies have consistently shown that bisexual individuals are at particularly elevated risk for negative health outcomes for reasons that we'll discuss in a few minutes. And we see similar trends for substance use disorders. So this is data from the 2015 National Survey on Drug Use and Health. The dark red bar is sexual minority or LGB individuals, and the bottom lighter bars are sexual majority or heterosexual individuals. And so you can see here at a population level, LGB individuals report higher prevalence of alcohol use disorder, cannabis use disorder, prescription pain reliever use disorder, which we can sort of interpret as a kind of opioid use disorder, and other drug use disorders compared to heterosexual counterparts. But I don't want you to walk away from this introduction thinking that there's something biological driving this. There's zero evidence for that. In fact, there's ample evidence to suggest that something conceptualized as minority stress may be driving many of these health disparities. And minority stress theory was a conceptual model developed by Alon Meyer in 2003, and then adapted by Hendricks and Testa in 2012 for transgender populations, that theorized that marginalized communities like LGBTQ plus individuals experience a unique and chronic type of stressor called minority stress that's derived from experiences of societal prejudice, discrimination, and internalized stigma. And in fact, over the subsequent 20 or so years, minority stress has been associated with elevated risks of depression, of hazardous tobacco, alcohol, and drug use, of hate violence victimization and subsequent post-traumatic stress disorder, and of other negative life experiences like bullying, workplace stress, unemployment, and homelessness. And so in this way, it's anti-LGBTQ laws, policy, stigma, and discrimination that really produce the disparities that we observe. And we could create a Venn diagram like this really for every social structure in society, including in healthcare. In 2015, the US Transgender Health Survey surveyed over 27,000 transgender adults and found that 23% reported delaying or postponing or necessary medical care in the past year due to fears of discrimination from their healthcare providers. And so because minority stress is such an important antecedent to substance use problems, and it's also present in our healthcare systems, our healthcare interventions really need to be responsive to this particular risk factor for this population. And so because of that, one size doesn't fit all when it comes to treatment. And so LGBTQ people, through numerous studies, report often feeling compelled to hide their identity to seek treatment, either implicitly because they don't see themselves represented in the environment in any way. That's something we call heterosexism, or explicitly by being discouraged to do so from doing so by providers or other peers, often with good intentions, but harmful outcomes. There are other policies that are often present in mental health care treatment, particularly inpatient settings, that may be harmful to LGBTQ plus patients, restricted access to personal items, some of which may have been really hard fought and hard won aspects of gender affirmation, and sex segregated treatment groups and living spaces that really leave out non-binary individuals and create some pretty rigid expectations and gender norms that may be uncomfortable for lots of folks, regardless of whether they're cisgender or transgender. And standard treatments rarely consider the context of sexuality and same gender relationships and how that might relate to substance use. And a prototypical example of this is crystal methamphetamine use among men who have sex with men, which often occurs in a particular subgroup of men who have sex with men in the context of sex. And we'll talk more about that in a few minutes. To make matters even more complicated, 71% of programs that advertise LGBTQ plus specific services don't actually offer them. This has been confirmed in 2 studies in 2007 and 2018. We haven't really made any headway on this. And this makes a filter like this down here, this LGBTQ plus filter on Psychology Today, really meaningless for most LGBTQ plus people. Some people use this as a signifier that they have deep experience with LGBTQ plus individuals or really intentionally think about it. Other folks maybe have some anecdotal experience with a relative or their own personal identity. Other people may use this sort of descriptor as LGBT affirming to just say, I'm not homophobic, I'm not transphobic. And that's not really helpful to LGBTQ plus folks looking for treatment. So there are two frameworks really for enhancing affirming care. And the first is universal affirmation. And we can think of universal affirmation as practices that are applied generally within a system to facilitate broad affirmation of sexual and gender diversity. And there are a couple of examples of this. One is by asking universally and making this a part of your practice to ask about sexual orientation and gender identity. So you can see some example questions here. People use different words to describe their sexual orientation. How do you describe yours? People use different words to describe their gender. How do you describe your gender? Asking these questions in an open-ended way allows patients to self-identify for themselves. And just asking the question communicates that you're interested in knowing the answer. Similarly, consistently inquiring about and using the names and pronouns that patients use to describe themselves can be incredibly impactful. And this includes in chart documentations and conversations where the patient is not present. In fact, in a recent study by Russell et al. That was published in the Journal of Adolescent Health, using chosen names in school settings was associated with fewer depressive symptoms and lower odds of both suicidal ideation as well as non-suicidal self-injury among transgender youth. So this can not only be just being a good person and being respectful to patients, but it can really impact health outcomes for this population. And one powerful way to do that in a clinic setting is by disclosing your own pronouns. And so this is an example of a provider wearing a pronoun button that says her pronouns, she, her, hers. And this communicates right from the very beginning of a visit that this is a normal part of treatment, that this is information that a provider wants to know and will respect. And so I wear a button like this when I'm seeing patients. Other ways are, placing, nonverbal signifiers of affirmation. These are LGBT pride flags here. Not gendering spaces that don't need to be gendered. So, putting signs on restrooms, particularly single occupancy restrooms that say use the restroom that best conforms with your identity. These sorts of things people notice in the environment and they communicate that this is a space where they'll be respected and affirmed. These are two treatment, I did a search for just some treatment advertising on the web. And so these are two that I pulled, and I want you to think about if you're a person looking for, if you're an LGBTQ person looking for treatment and you see an ad like this, what you're gonna think about, am I gonna be represented in this space? Is this a space that can sort of hold and affirm my identity? And I would argue probably not, or at the very least, you're not sure. When you see advertisements that only feature different gender couples, and in this case, mostly white presenting individuals, you're not really sure about what this treatment program is going to be like or what it's going to be like to be a queer person in that space. And so just including different relationships, family configurations, identity presentations in our posters and advertisements and materials can go a long way in also creating this environment. And these are two publicly available posters that we created as part of a project, my colleague Margaret Passion-Wolf and I, with the Opioid Response Network, and I'll include the link to that and some training materials at the end of my slides as well. But you can see, these are pretty universal affirming messages about families and about recovery, but we've just sort of swapped out some of the pictures and made them a lot more inclusive. And in many cases, that's a really important first step and maybe even sufficient in offering affirming treatment. But for some individuals, we need to go a little bit further, and that's where cultural adaptation comes in. So cultural adaptation considers culture, language, and context to increase treatment compatibility with patients' cultural norms and values. The cultural sensitivity framework that's depicted here is one example of that. And this framework considers both surface structures and deep structures that are related to substance use in a culturally specific context. So examples of a deep structure might be thinking about risk factors for substance use, like we mentioned, crystal methamphetamine and sexual behavior. Surface structures might be thinking about people and places. We might be thinking about LGBTQ bars. We might be thinking about particular vernacular. So thinking about Tina, which is a common slang used to describe crystal methamphetamine. and really sort of tailoring treatment to make it more relevant to the individuals who are seeking treatment. So here's just one example of a study that was done in 2005, but has subsequently been replicated and turned into a full treatment program. And this is culturally tailored CBT for crystal methamphetamine use among men who have sex with men, or MSM. This was a 4-arm randomized RCT that compared standard group-based CBT, voucher-based contingency management, which is a common treatment for stimulant use disorder, contingency management plus standard group CBT, and then a culturally tailored CBT. And they recruited 40 adult MSM with recent crystal methamphetamine use. And the tailored elements really centered around incorporating discussions of locations like circuit parties and context such as sex when discussing CBT topics. All the core CBT principles are there, the CBT exercises, the homework assignments, but incorporating those deep and superficial structures into the discussions. And there's a lot of information on this slide, but basically, if you look at the first line, percent completers, we can think about retention or completion in treatment, and then, or completion, and then we can think about retention on the third line. And you can see that in many cases, the contingency management groups outperformed the standard CBT in encouraging people to complete and to retain treatment, and perhaps not surprisingly, sort of out of the scope to go into detail about what contingency management is, but contingency management really outperformed CBT when it came to consecutive stimulant negative urines over the course of treatment. But where the culturally adapted treatment really came in and made the difference was when we looked at rates of when the authors looked at unprotected receptive anal intercourse, or bottoming at termination of the treatment. So past 30-day unprotected anal intercourse. And CBT really outperformed the other treatments in reducing that risk behavior that is so commonly both a trigger for substance use, as well as one of the major health risks in terms of thinking about HIV acquisition. And you can see that here too. This yellow line shows CBT way outperforming the other the CM alone or standard CBT therapies in reducing the mean number of unprotected receptive anal intercourse episodes in the past 30 days. And this has since been replicated and turned into a full manualized treatment that you can access at this. It's called the Getting Off treatment, has some really great sex positive advertising, and you can go to friendsgettingoff.org, which is a program run by Kathy Reback and Steve Shoptaw in West Hollywood, and download this manual and look at the worksheets and incorporate it into your work with patients right away. And so just by wrapping up, I'd like to share with you a little bit about what my group is doing to sort of also think about culturally adapted treatment. And so we're looking at interpersonal psychotherapy as it relates to transgender individuals with alcohol use disorder. And our prior research showed that alcohol upticks were really happening, like 2 of the periods when this really happened were during gender transition and some of the stressors that came along with that, including the interpersonal disruptions that came along with that. You can think about changes in romantic relationships, changes in friend relationships, meeting new people. And in IPT, we would conceptualize those as role transitions and role disputes. And so we're in the process now of tailoring, and then we'll begin recruiting in the fall for a clinical trial of culturally adapted IPT with transgender individuals with alcohol use disorder. So more to come on that. And then last, if you want to learn more about this, I would encourage you to check out a free training with free CME that Margaret Passion-Wolf and I developed with the Opioid Response Network with the support of Francis Levin and others in the ORN, that contains video-based demonstrations of waiting room encounters, of group therapy scenes, and provides instruction on how to address homophobia and transphobia that might come up in group therapy, how to improve the experience of patients coming in, and is a really, I think, fun, interactive way to learn that material and demonstrate it for others. And so just by way of summing up, we know that LGBTQ people experience higher rates of mental health and substance use problems than heterosexual populations. This is explained by minority stress, that culturally responsive treatments are often not available, that universal affirmation can improve treatment engagement, And if we take that one step further, cultural adaptation can really improve the effectiveness of our treatments for often marginalized populations by making it more relevant to the context of substance use. So I'd just like to thank my mentors and my research collaborators, and I've included references at the ends of the slides that'll be uploaded later. Thank you all for your attention.
Jeremy, that was great. Thank you so much. And now I'm excited to check out the training videos. So let's see. And you reminded me that I had neglected in my enthusiasm to get started with our talks to give the title, the overall title, the unifying title of today's clinical session, which is Reaching the Margins, Tailored Treatment Approaches for Addiction. And exactly as Jeremy said, you know, speaking about getting our treatments to vulnerable populations. And so our final speaker for today is Dr. Sam Lookatch. Dr. Lookatch earned her doctoral degree from the University of Tennessee. She completed internship at Hazelden Betty Ford Foundation and a postdoctoral fellowship at the VAMC in Philadelphia. Her research has broadly focused on addiction treatment outcomes, with her fellowship work addressing the role of social support in the enhancement of addiction treatment for veterans. And she currently serves as an associate editor for the Journal of Couple and Family Psychology, Research and Practice. She's a licensed clinical psychologist specializing in the treatment of substance use and other co-occurring mental health disorders. And she's passionate about aiding patients in improving their communication skills and relationships to improve function and satisfaction. She's provided care in a variety of settings, inpatient, residential, and outpatient clinics. And she practices in the Smithers Center within Columbia Doctors Midtown, providing treatment through assessment, individual, couple, and group therapy. And so we're going to shift gears a little bit to think about family interventions now. The title of Dr. Lookatch's talk is Family Matters, Use of Craft Family Group to Improve Outcomes for Individuals with Substance Use Disorders. So welcome, thank you so much.
Thank you for the introduction. Get my slides up. Oh, let's start my show, sorry about that. All right.
So we can see the presenter view.
Okay. Is that better?
Perfect.
Okay, sorry about that. Always fun to start with some technical difficulties. So thank you for the introduction. I'm really excited to talk to you guys about family inclusion in substance use disorder treatment, and specifically the CRAFT model. I have no disclosures to report. So over the past several decades within addiction research, studies have continually yielded findings indicating the benefits for patients and their recoveries, and also their families, when family members or social supports are included in some capacity in treatment. Unfortunately, there are several issues that were previously mentioned in some of the prior talks that make family inclusion really difficult. The first is that sometimes family members see the individual struggling with substance use disorders as the problem, and they have this faulty belief that if they get treatment, then there won't be any more problems within the family. Realistically, of course, many of these problems predated the substance use or addiction and won't simply disappear with abstinence or sobriety. Additionally, patients sometimes already feel really controlled by their family members, as the family, in an effort to help manage the addiction, may engage in controlling behaviors like searching for and discarding substances, wanting to know where their loved one is at all times. And family members struggling with the addiction see this as really intrusive, of course. So when they engage in treatment, sometimes they want treatment to be their own. They don't want family members included. Additionally, sometimes they feel such significant shame about the burden that they've already placed on their family that they're unsure about asking family members to also participate in some type of treatment. Separately, many programs unfortunately don't offer family components for treatment, and a lot of those that do tend to be residential treatment centers. So with these, they can be far away, typically not in urban centers, so less accessible by many people. Additionally, when they do have programs, there may be a significant cost to participate in those programs that families may be unable to pay for because they're already strapped to pay for the treatment. Additionally, there can be childcare issues if one partner's in treatment, the other one can't then leave to obtain treatment as well, transportation difficulties, and also timing. As previously mentioned by Dr. Williams, a lot of our treatment is from 9 to 5, which is typically when most people are working. So if we're asking them to take off work, that can be another financial burden for them, or they're unable to make it to the clinic in time. So with these difficulties, we do have treatments that are available and out there currently, and they fall into kind of two broad domains of self-help group and more formalized treatments. The self-help groups, many of you are likely already aware of, the 12-step groups in particular. There's of course Al-Anon and then Nar-Anon, in addition to adult children of alcoholics meetings and Families Anonymous. For teenagers, there's also Alateen and Narateen. For some people, they don't find these groups that are free and available widely across the US to be open or accessible because they are religiously based and sometimes can have a little bit more rigid structure. Additionally, these groups can vary by quality significantly depending on who's there and location. Other non-12-step or higher power-based programs that are available are things like Smart Recovery, which actually is built on CBT principles, Broken No More, which is a social media-based support system, the Parents of Addicted Loved Ones, which has both in-person and online supports, and then finally GRASP, which is a group for individuals who've lost someone to substance-related issues. Our more formalized treatments, of course, include just general supportive therapy for family members who are struggling with a loved one who has substance use issues, and also behavioral couple therapy, which has shown promise in research when administered to a couple struggling with addiction. Unfortunately, with these first two, a lot of more general providers may feel uncomfortable or that treating someone with addiction issues is outside of their expertise or niche. And while they may be able to find providers, these providers may not be able to provide addiction-focused treatment. Additionally, there's peer support specialists through the Partnership to End Addiction. A lot of these individuals experienced struggles with family members with addiction themselves, obtained some training, and then are able to help other people in a peer capacity. Finally, what we're going to be focusing on for the rest of my talk is the community reinforcement approach and family training model, also known as CRAFT. CRAFT was created by psychologist Robert Myers, who as a child grew up with a parent who struggled with substance use disorder, and then also in his own adulthood struggled with addiction. He recognized the impact this had not only on him, but also on his mother and family unit. And he understood that there was a wealth of knowledge and insight that he and his mother had regarding his father's addiction and process, and thought it would be really effective to use this as a tool to help positively impact treatment engagement and the overall relationships and family dynamics. So CRAFT is an evidence-based treatment that's been around for 15 to 20 years. And it focuses on providing support and skills to concerned significant others, or CSOs, as the CRAFT model refers to these family members and social supports who really want to support their loved ones struggling with substance use. When we look at the outcomes from individuals who've engaged in CRAFT treatment, we see benefits not only for them, but also for the individuals struggling with substance use disorders, which is really awesome considering they're not even a part of the treatment. These benefits include an increased likelihood of treatment engagement and retention for the loved one who's struggling with substance use disorders. Getting someone in the door for treatment is often half the battle. Once they attend, having them continue in that treatment, as was shown, I think in the last presentation, retention rates sometimes can be pretty difficult with substance using populations. So engaging in this can really help individuals support their family members so that they actually stay in treatment. A byproduct of that, of course, is then decreased substance use, which is really excellent and our overall goal typically. With the family members or CSOs obtaining treatment and ideally their loved one obtaining treatment, we see improved relationship satisfaction. Lastly, family members tend to experience significant mental health issues when they're struggling with a loved one's addiction and substance use. We tend to see some of the same types of increases in mental health issues like depression, anxiety, anger. And when they obtain this treatment, we actually see decreases in the CSOs in these mental health issues. So how does the treatment actually work? It has 4 main tenets. The first is to provide just basic psychoeducation on substance use and addiction to family members. Often they don't really have this information. They may have just some basic information from what they've seen on TV or potentially in news articles they've read, but we work on providing the disease model of addiction and helping the family members understand what happens to the brain when someone is engaging in repetitive substance use and how this drives addiction, in addition to the basic criteria for a substance use disorder. Next, we focus on behavioral principles and motivational enhancement strategies. And this is where we can really help with treatment engagement and retention and a decrease in substance use. We focus on reinforcement, positive reinforcement of the abstinent behaviors. So thinking back to Psych 101 information, where we want to make sobriety and abstinence look really attractive to our loved one again. So when they aren't using or when they're sober, we want to engage in activities that they find pleasurable. This can be something as simple as going for a walk together, preparing a meal, picking a TV show or movie to watch together, anything that they find enjoyable that you can, that the family members can do to help maximize their interest and willingness to engage in sobriety. Secondly, letting their loved one experience natural consequences from their use. Family members, out of love, often will prevent their loved ones struggling with substance use disorders from experiencing the negative consequences from their use. This can be something like in the morning, taking their partner or loved one a glass of water and some ibuprofen, making them breakfast if they're hungover because they know that they won't feel up to doing those things, waking them up for work, waiting for dinner until they get home. Any of these types of really small behaviors that unfortunately and unintended will reinforce their use because they know that their loved one will be there to help them or take care of them in a way that prevents them from experiencing natural consequences. When the loved ones stop doing this and let them experience these natural consequences, it can actually build their motivation to change. Next, we focus on teaching them effective communication skills. This really looks a lot like basic assertiveness training, with a significant emphasis on using positive language as opposed to negative language. These are really small changes that family members are often really surprised can make an impact. And once they start employing them, see benefits and change pretty significantly, almost immediately. And these can be things like, instead of nagging on a partner and saying like, I hate when you're using, it's awful to be around you, instead telling them, I love when you're sober. I have such a good time with you. I feel like we really connect in a meaningful way. Really getting at the same construct, but with different language that yields significantly different outcomes. Finally, CRAFT emphasizes the self-care for the family members. The addiction or the substance use has really taken a toll on them as well. And we want to make sure that they're looking at how they can take care of themselves again to bring back meaning and enjoyment to their life. This can be simple things like self-rewards, giving themselves break or space, having support to actually talk about what's been going on, because often they're very isolated in shame around the use as well, and then potentially disengagement when necessary if there's safety concerns. So these are the 4 basic tenets of treatment, which for us in the Smithers Clinic, we've been delivering virtually now for about 2 years. And interestingly, we have seen some positive impacts of the pandemic on CRAFT delivery. So some of these benefits have been that those barriers I mentioned previously are often removed because there aren't transportation difficulties. If I don't have to go somewhere, I can actually engage in treatment from home, or if I'm in the office, from private space there. Childcare issues also, depending on the age of child, of course, can be managed much more easily as well, because I can be home if I'm going to participate in treatment, so I don't need a babysitter. I just need to go in a different room and have privacy. There's also increased scheduling flexibility and availability regarding, time of day. If I'm working 9 to 5 and my group starts at 5:30, whereas before maybe I wouldn't be able to make it home in time or make it to a clinic, now I can easily transition from work to a group or a session, because I don't have to factor in all of that extra time. Finally, there's a reduced perceived burden of actually engaging in the group, both by the individuals struggling with substance use and their family members. It's not quite the same strain as going into the clinic and being uncomfortable and partaking in this activity, but they can do it from the comfort of their own home. There's less effort that may be needed initially to log on than to actually present for treatment. Some of the potential concerns or drawbacks that has been brought about by the pandemic include, of course, privacy, concerns due to spacing. A lot of our individuals, especially in the city, if they're in a 1-bedroom apartment, there's worries about, can my partner hear me? I don't want them to hear what I'm saying. So we do think about how they can provide themselves the space to speak freely and really engage in the group. Interestingly, Levy and her team did find across the pandemic that it can actually be helpful if there are multiple people participating in a session or group to separate out within the home if it's virtual care, so that they can be more attuned to facial affect and respond empathically, as opposed to having someone sitting next to you, or the difficulties of getting multiple people on camera all at once. So the virtual care has been an interesting shift for us, and definitely led us to be able to include more individuals in our craft program that we provide. And now I want to share a case example with you. Okay, so this was one of our patients that we had. We'll call him Avi. He was a 54-year-old male with an alcohol use disorder, major depressive disorder, and significant social anxiety. He was engaged in individual therapy and addiction psychiatry through the Smithers Clinic, and his providers were referring him for our evening outpatient program, the Columbia Co-occurring Recovery Program. This is a program for individuals struggling with mental health and substance use disorders, where they learn skills through relapse prevention, CBT and DBT content specifically for substance use disorders, and interpersonal process. The patient was initially incredibly ambivalent about remaining adherent to the antabuse that was prescribed to him and engaging in the group because of his social anxiety and his just kind of general ambivalence about abstinence. He had concealed his drinking from his spouse for several years, so also didn't really see significant consequences to his drinking at this time. He was able to participate in CCRP, and as such did invite his spouse to participate in our craft-informed family group. When his spouse did participate, she, through the course of the group, was able to build a better understanding of addiction and really generate more compassion for her partner around his efforts to remain abstinent, what treatment was like for him. A lot of times our family members don't know what group therapy is like. So when they can participate in something like this, they really start to understand the process for their loved one. She was also able to learn appropriate boundaries around what was her job to share and what really she should be leaving for him to share about his addiction and substance use, while she could still reach out for support but provide him that privacy. This was really significant for them in their relationship dynamic. She also was able to adjust her expectations around what recovery would look like for him and changes within their relationship. He was drinking a lot previously to manage his social anxiety for different social activities she wanted to do. And she had to understand if he wasn't drinking anymore, he may not be as willing or open to engaging in some of those activities. So negotiating what that looked like as well. Finally, with both of them, they were able to start to recognize the importance of engaging in mutually enjoyable activities. They ended up picking a TV show to watch together, and also have been really working to try to navigate more difficult conversations around uncomfortable emotions for both of them. The patient subsequently successfully completed CCRP, and then even decided to engage in our alumni group, which is really fantastic. He's, I believe, on his 3rd cycle of the alumni group and is really invested in his treatment. So much so that he and his partner are now actually considering couples therapy, which is really excellent. It's been a recommendation for them for a long time, and they're finally actually thinking that this might be something that could benefit them. So available craft services for providers or referrals within Columbia. There is the Columbia Gambling Disorder Clinic that provides individual craft-based treatment for concerned significant others and family members. Additionally, as I mentioned, in the Smithers Center where I'm located, we have a craft-informed family group, and we also provide individual craft-based treatment for family members. Separately, there's the Center for Motivation and Change. They have a really wonderful free monthly meeting for people to attend. It's virtual presently, so people can attend it really from all different places, and it's at no cost. And then they also do have at-cost individual treatment for concerned significant others. There's a virtual platform through We the Village, and then of course the book that the creator of Craft, Dr. Robert Myers, authored with Brenda Wolfe, called Get Your Loved Ones Sober. Here are my citations, and then my contact information. Please feel free to reach out for further questions or treatment referrals for Craft as well. And now I'll turn it back to Dr. Miller for questions.
Great. So yeah, I'd welcome all of the presenters back. Sam, that was a fantastic talk, and we just covered such a breadth of domains within the area of addiction treatment, but there are a lot of common themes and about adaptation. One common theme is about adaptations during the pandemic, for sure. I would welcome people. We've had several great questions already that we're going to start going through, but I would welcome people to put questions in the Q&A, not in the chat, but in the Q&A. I'm going to start with a question, Robin, for you from a trainee, from a fellow Manesh Gopaldas, who I think is asking about sort of how this has extended to other forms of agonist replacement therapy. So he said, first of all, he said, great talk. And he said, how has regulatory reform during the pandemic changed methadone prescribing? What progress has been made around methadone teleprescribing and access in non-traditional settings?
Sure, thank you. So this is a great area I'd like to talk about it. So just a reminder, so when we say methadone prescribing, it really conjures the idea of an outpatient prescriber writing a prescription, the patient taking a prescription to a community pharmacy. And that only happens in the US for methadone for pain conditions. So it sounds a little bit counterintuitive, but to receive methadone maintenance treatment for opioid use disorder, patients, since the conception of methadone programs, with very few exceptions, have always had to go to federally and state licensed OTPs, methadone maintenance treatment programs, which are now called opioid treatment programs. What did change radically starting March 15th, in part because of New York, frankly, pressuring SAMHSA, which then SAMHSA allowed for all of the states to apply for a waiver at the sort of onset of COVID in March 2020 to be allowed for, and these are the official terms. So stable patients could receive up to 28 days of medication at a time from their clinic rather than attending daily. And somewhat stable patients could receive up to 14 days of dispensed medication, which really means one in-person dose and then 13 days dispensed of take-home bottles that they could have to minimize the need for travel and in-person interactions, and more or less suspended drug testing and group attendance requirements. So this was beyond, I think, what anyone could have ever anticipated or even proposed for methadone programs as realistic changes preceding COVID. To get in the weeds a little bit more, remember, first of all, that the feds have, as with so many things in the US, the feds can have laws, and then states can layer on additional laws and be more restrictive. And we've already seen that. I was talking about the Ryan Haight Act for initiating controlled substance prescriptions that historically had required in-person visits, and that's been temporarily suspended. But there are probably at least a dozen states that have more or less put that back into place. So the states can be much more conservative. Wyoming is an example. The state of Wyoming doesn't even have methadone programs. So to Manish's question, that there's this interest in alternative models for methadone maintenance treatment, and peer nations, Canada, Australia, the UK, have three-party contracts between a prescriber, a pharmacist, and a patient, where the patient can basically have prescriptions go to a community pharmacy. This is very appealing, and I've been in support of this for a long time. I mentioned 40% of US counties don't even have a single buprenorphine waivered prescriber, but 95% of people in the US live within something like 5 miles of a community pharmacy. So if we think about the reach of about 1,200, 1,500 methadone programs in the US, we have tens of thousands of community pharmacies. So there's a lot of interest. I've been excited to be part of this, but to know that it exists. NIDA's Clinical Trials Network has put together a work group on methadone reforms. And then also I have a NIDA CTN funded study to look at the patient outcomes who are stepped out to the 14 and 28 day take them. So this is a big area of not just one or two, but many different kinds of reforms that could increase access to methadone that all of a sudden seem like real possibilities because of COVID.
Great, thank you so much. And Sam, I'll send a couple of questions your way. There are two related questions, one from a trainee and one from Meg Haney, asking about the sort of clinical trial base supporting the efficacy of craft. So Meg was asking how you demonstrate the efficacy of craft and what the comparison groups are. And the trainee's related question is, has craft been compared to other family-based interventions?
Yeah, thank you for the questions. Those are excellent questions. I need to do a little bit more research to confirm those answers, but I know there are several efficacy studies available on craft. I think as far as the comparison groups go, I don't know that they were comparing specifically against something like BCT, behavioral couples therapy, but likely against just like general individual therapy and or 12-step or self-help group models. Additionally, the other question was related to...
Well, just the evidence base and if it's been compared to family intervention. So related questions, yeah.
Yeah, and as far as like what we would look for to assess would be, looking at treatment retention or engagement if a patient, if the loved one was in treatment prior to the family participating in craft, how long they were able to stay in treatment compared to, control groups where the individuals didn't have family members participating in craft, but with similar family relationships as well. In addition to then looking at longer term outcomes of treatment retention and abstinence rates. And there's a happiness scale that they also typically use as a questionnaire to kind of assess changes in that, and then also relationship satisfaction questionnaires.
I'm so sorry, my computer froze. I was unable to communicate. Can you hear me?
I think it's good now.
Oh, thanks, sorry, I was struggling. Jeremy, you are up next. Thank you very much for that, Sam. You have a question from William Tucker, who asks about differential rates of mental health symptoms as a function of sexual orientation, and asks, how do you understand the greater incidence of mental health symptoms specifically among bisexual and questioning people than in heterosexual and homosexual people?
It's a great question, and thank you, Dr. Tucker. I also was struggling with internet issues, so I'm joining with my phone now. But yeah, it's a great question. So some of the studies that have looked at that have looked at the experiences of minority stress for bisexual and questioning individuals and how that might differ from individuals who identify as gay or lesbian, and so or heterosexual. And one of the particular stressors is both with like in-group and out-group stressors. So the outgroup stressors being like the stressors of existing as a sexual minority in a predominantly heterosexist society, and the in-group stressors are also the stigma that exists within LGBT populations toward bisexual individuals. And this is something that I think has gotten better, but still continues to be a struggle in terms of like figuring out finding your home. I mean, if you think about the vernacular, we often talk about gay bars or something, and like what does it mean to be a bisexual individual who is partnered with somebody of a different gender? So you're viewed by the world potentially as being in a heterosexual relationship, and the ways that might be invalidating of somebody's identity and experience. And so I think that's one of the reasons that the emphasis recently has been placed on this idea of universal affirmation, because the reality is that we as clinicians, or just people in our lives, really never know who we're talking to until we get to know them. And so it's sort of challenge. So assuming that anybody that we interact with could be LGBT is a way of providing that affirmation to everybody, even if we don't know how they identify, or maybe never know how they identify. It can still be really important to them. I hope that answers your question.
Great, thank you. Robin, I'm going to combine questions from a trainee, from Liz Guthrie, and from Forrest Foster, who all asked you more about the patient populations that you've worked with in the retention study, and maybe more generally with the Ophelia program. So one question was just about what more details about the patient population: shelter, homeless, high SES, race, ethnicity, and then another was about developmental disabilities.
Sure. So the good questions, of course. The about 2/3 of the patients. So we know that 80% of the patients have Medicaid plans, and 2/3 of the patients, it really was around, I think, 66% self-reported race, ethnicity, and they reported 88% of them reported white. And that is in lockstep with most other buprenorphine, multi-site, multi-state buprenorphine studies. And this is a long-standing trend and speaks to a lot of structural factors, environmental factors, where treatment has been located historically. So it's not a surprise at all. The SES question is a little bit harder, although I think 80% Medicaid speaks to that. The numbers I didn't include because of time in terms of the rural-urban breakdown. We didn't see any differences. There were non-significant differences in retention. Maybe there was a trend that urban had slightly higher, but it wasn't statistically significant. But 79% of the patients were from metropolitan areas. So that would be, in a big city or near it. And then 21% were in really rural, small town America. And that was represented in the heat maps, I think, pretty well, just visually looking at those. So it was, I think in some ways, it was a more diverse patient population in terms of geographic distribution, but seemed to be very similar in terms of Medicaid composition and race, ethnicity to what I've seen in other studies. And this is where it's very tempting to, especially, I think we're all now accustomed to using EHRs, but with telehealth and the nature of virtual interactions, people accessing care, at least initially or in part, through computers, smartphones, it's really tempting to just have endless surveys and collect tons of information. And so the balance is trying to figure out how to have the most useful information, but to do it both in a therapeutic way that enhances retention, while also along those lines, minimizing the burden on patients, and then just having a lot of noise and data that we can't actually use. So I would love to drill down on homelessness or developmental disorders or disability or things like that, but we just don't have the richness of that data at this point.
Got it. Thank you. Sam, I wanted to ask you a question about sort of engaging family members and how engaged sort of the identified patient with the substance use disorder has to be according to the CRAFT model. Like I think about like Al-Anon, which I think someone might participate in with their family member in any stage of treatment or non-treatment. And so how does that work with CRAFT? And in your setting, it sounds like the patient must be actively involved in your program for the family member to participate in CRAFT. Is that right?
So actually, for CRAFT, a family member doesn't have to be engaged in treatment. And in our clinic, they actually don't have to be engaged.
I see.
If they are engaged already, like typically for anyone who comes in for our evening program, we always offer it and encourage family members to participate, or loved ones or social supports. But not everyone takes us up on that offer. And we do have other people who, have found us through other referrals or other providers within our clinic who recognize, they're treating someone who's struggling with a family member with addiction, and that this could be a really great resource for them. So they don't have to, the loved one doesn't have to be in treatment. And in a lot of cases, where CRAFT was developed, some of it was actually to help motivate individuals to get into treatment. So it can be really effective either way.
That's great. Thank you. We have a question from Catherine Castro, and I think this really may be for everyone who's doing telehealth work in the session. Catherine asks, have you noted economic barriers for patients and their ability to access the telehealth service / use the online platform, i.e. access to a smartphone or computer, internet access? Yeah, so if any of you who have experiences you can share about that.
I'm happy to talk a little bit about that. I've actually only been with Columbia for just over a year, and I came from a VA system, so a very different population. I'm in Philadelphia working within addiction there as well. And I will say, it's surprising how many people actually do have smartphones and the ability to participate within the clinic that I work in through Columbia Doctors. We don't see really significant financial barriers for people to be able to engage in virtual care. Previously, while I saw that some when I was working with a different population, everyone had a phone. So minimally people could engage in audio treatment, but typically they were able to use either a cell phone, which works fine for the virtual platforms, or have a computer, laptop, or tablet or something like that.
Robin, do you have any comments about that from your work?
Well, this is an important area, and I think it is something the whole country is grappling with in terms of thinking about, especially in rural areas or low-income areas where people don't have and I think the question, invokes this. It's not just about having the device. People have to have the minutes. I think there's some things that a lot of us as professionals or clinicians, I'm guessing we all have consistent access to, even despite the tech troubles we've had today. We're not counting our minutes, or our broadband and things like that. But those are very real things that people deal with all the time. So, I do think at the same time, we need to have some nuance, because for just anecdotally, I've had difficulty with new patients, phone only, long stories, but phone only. Whereas for long-standing patients, I've seen, weekly or regularly for years, phone has been seamless. But at the same time, I think for new patients and for more complex presentations, having at least visual is important at the outset, just to have a better sense. And then of course, there's also at scale, there's a larger concern about what kinds of incentives or unintended incentives may be packaged into regulations or laws that allow for certain kinds of practice. And unfortunately, there can be fraud or bad actors, and so we need to have some sort of constraints on the way that people could take advantage of what's allowed. But clearly, the tech access is going to be an ongoing thing.
Jeff, if I could just add like a public psychiatry perspective here too. Working in the Washington Heights Community Service, the pivot and the sustained use of telehealth has been really challenging for quite a number of patients, and some of them do have to do with economic reasons. But I think as Robin was saying, there are other things as well that sort of get in the way. And this is about minutes. It's about internet access. It's also about having a private space to be able to see somebody. If you are living in a multi-generational apartment with 2 bedrooms, I saw a patient the other day, and she's simultaneously taking care of 2 children while trying to see me, and I felt torn, like maybe I was actually doing more harm in her life by distracting her in this moment. And so it can be really challenging, I think, for a number of patients. And so I'm glad that I think there's a lot of promise in telehealth, particularly in LGBTQ health, of reaching folks who don't live in large urban areas. But I hope that we don't pivot so far that we begin to create sort of new disparities. And this is true for folks with severe mental illness too. I think folks with severe negative symptoms have a really hard time engaging in telehealth and maybe and navigating some of the telehealth platforms. And so in person has been a really important part of the work that I've been doing still.
Great, thank you. Jeremy, I wanted to ask you a little bit more about, your presentation was so fascinating, and I'm excited to look at some of the training for culturally adapted treatments, although it's outside of the sort of domain that I treat in working, with substance use disorders. And so that made me curious about sort of resources for clinicians who want to get better educated and trained in culturally adapted treatment with a broader scope outside of substance use disorders. If you have recommendations about resources and even sort of anecdotes about what some of those adaptations might be more broadly in psychiatry.
Yeah, I'm glad you asked that, because when we put together that training, we really intentionally tried to focus on principles that were really relevant in any setting. And so, for instance, the vignette that's a group therapy setting, it is a therapy where people are discussing their substance use, but you could easily swap out feel like mood words or anxiety symptoms for some of the substance conversations, and it becomes more about general skills. So what happens when a patient makes a discriminatory or stigmatizing comment toward another patient? How do you, as a group therapist or facilitator, intervene in that setting? And so I think that there are still some particular, some helpful guidance in those training videos. I mean, one of the things in that example, we encourage people to name directly the behavior. And so it can make us as therapists very uncomfortable. It's conflict. We worry about alienating the person that made the stigmatizing comment, who also needs to be in treatment, as well as the person who felt, but really calling into the room in an explicit way those comments, and to the point that, and making a very clear line that this is not acceptable, and but also being open to meeting with that individual later who made the comment to engage them in session. And so I think those are some of the kinds of, if we talk about universal adaptation, that can be really helpful. In terms of cultural adaptation, I think a big way to do that is to just be curious about the ways that your patients are using substances or the context of their symptoms, and inquiring about non-traditional families or non-biological family, non-traditional sources of support, thinking about trauma in a really broad way, including trauma that's related to discrimination or hate violence, thinking about the use of apps, and in particular dating or hookup apps that might be different for LGBTQ people, both in the particular apps that they're using, but also what it represents, that it might represent the only connection they have to other LGBTQ people, but it can also be a source of online bullying and stress and being offered substances. And so it can really be a double-edged sword. So those are some ideas that sort of come to mind, and how that might be applied more broadly.
Wonderful, thank you so much. We have another trainee question for Robin from Ashvin Sood, Child and Adolescent Psychiatry Fellow, who says, as the private sector expands in this market, ads for cerebral and done mental health private clinics that advertise heavily on providing telepsychiatry healthcare are increasing. Are there pitfalls that these private entities fail to consider from a legal and ethical perspective, particularly when it comes to Suboxone prescription?
So I'll try to be objective here. I think we're moving in a direction where there are a lot of companies that are selling products, and maybe a quarter or a third of what I do is on cannabis regulation and medical cannabis programs and whatnot, where we're approaching what's basically over-the-counter sales, not just of prescription medications, but controlled substances, whether those are cannabis products, cannabinoid products. stimulants, hormones, opioids, psychedelics like ketamine and psilocybin. I think most people have seen this because it's all over the news. And I think some of the slides I had where it just showed there hundreds and hundreds of telehealth companies. There is so much happening, and this is a Wild West that I think even eclipses the Wild West of cannabis that has changed so much in the last 25 years, cannabis regulation, where I think we have now something like 36 states with medical access and 18 states, 8, 10, I can't keep track, it's in the teens, I think, with adult recreational access. So I think all of this raises a question of sort of a meta question in the US of how should people have access to substances, whether they're prescribed, not prescribed, controlled, not controlled. Of course, we have a lot of novel substances. So this is bigger than your question, Ashwin, but I think it's really important. And I remember several years ago as the regional director for New York AAAP writing to our listserv about when I think it was Hems or Roman, but one of them had pivoted to offering basically sertraline for premature ejaculation. And my concern was that all of a sudden people, this is along the lines of over-the-counter sales, where you go on, you log into a website, you enter some information, and within 5 minutes you get approved from some sort of virtual doctor or bot or something like that to have access to a prescription that in the past required you seeing a licensed clinician who would see you and evaluate you and take a full history, and or at least a targeted history. And then who would really monitor you and follow up. And this gets into the longitudinal relationship versus one-off sort of sign-offs from people who may not even know the individual patient. Cerebral, I'm not going to know the number, but I think has just closed funding for something like $100+ billion valuation. They have prescribed to over hundreds of thousands of patients in the country, and I believe for all sorts of mental health conditions. And I believe part of their hope is to use machine learning to identify, for precision psychiatry to match patients to medications. I think in terms of ethical and legal concerns, a lot of the, maybe counterintuitively, a lot of the companies in the mental health, telehealth space don't have mental health experts in their leadership. They may have clinicians from other fields of medicine or nursing, but not people who are familiar with mental health conditions or specifically substance use disorders or specifically opioid use disorder. Now, regarding Suboxone, the reassuring thing about buprenorphine, and this is why it is Schedule 3 rather than Schedule 2 like methadone, is because it really doesn't increase risk of overdose. It really decreases risk of overdose. And at the same time, we've heard that there are companies where people can go to a website, put in information, and get a 30-day prescription for 90 strips of 8 milligram buprenorphine. So it's 24 milligrams a day for a month's supply, which is the top of the FDA indicated dosing, way above the average dose in clinical practice, but not an unreasonable dose. But if we're going in the direction where a lot of people can go online and get that many doses of buprenorphine, obviously there are going to be major concerns about diversion. And that's something that, at least with the one telehealth company that I've been working with, we've been very careful about in terms of drug testing and monitoring. And frankly, the insurance companies don't want to be a network with providers who don't have oversight of what's happening with their patients. So I think the wild and loose companies are a threat to high quality companies that are really helping reduce disparities and get access to people with evidence-based care. And that if this gets too out of control, then you'd be concerned that state or federal policymakers are going to clamp down on it in a way that's actually really harmful to a lot of patients and providers who are doing good work.
Well, that's a cautionary note to end our session on today, but it's amazing to hear the great high quality work that the three of you have been doing, both in person and remotely. So thank you all for presenting today. This was a really fantastic session, and look forward to next week's Grand Rounds. Thanks, everyone. Have a great day.